Excellent. So we'll go ahead and get started. So welcome to our last day of our virtual neuromuscular conference. We are very grateful to have Dr. Leanne Ward here today to talk about bone health and osteoporosis in Duchenne muscular dystrophy. Before I go on to sharing her bio and introducing her topic, what I'd like to do is remind you all that today's webinar is available in English and in French. And so on your screen, you will see an interpretation icon. You can select English or French, the language of your choice for today's presentation. I'll pass it over to one of our directors of mission, Marie-Hélène Bolduc. So she'll explain this instruction as well in French. Go ahead, Marie.
Oui, alors bonjour et bienvenue à tout le monde pour cette première conférence de notre dernière journée. Je voudrais vous dire que si vous voulez écouter la présentation en français ou en anglais, il s'agit d'aller sélectionner l'icône en forme de globe dans le bas de votre écran et vous allez sélectionner la langue de votre choix tout au long de la conférence. Vous allez entendre cette langue-là. Si vous voulez poser des questions en français dans le chat, vous pourrez le faire en français et je poserai vos questions à la toute fin. Merci beaucoup.
Thank you very much, Marie-Hélène. So as I mentioned today, I'll just make sure I am on the English line as well. There we go. Dr. Leanne Ward is here today. Dr. Ward is a professor of pediatrics at the University of Ottawa, where she has held a research chair in pediatric bone health since 2010. She's a medical director of the Pediatric Bone Health and Rare Disease Bone Disease Clinical and Research Programs at the Children's Hospital of Eastern Ontario, CHEO, and a pediatric endocrinologist in the Division of Endocrinology and Metabolism. Dr. Ward has previously received an MDC grant, one of our annual seed grants, and we're really grateful to have her here today to talk about part of her project. So I'll go ahead and stop sharing my screen, Dr. Ward, so you can share your presentation.
Bon, alors, bonjour tout le monde et merci de l'opportunité de parler avec vous concernant l'ostéoporose chez les enfants, les adolescents avec la maladie Duchenne. Good afternoon, everyone. It's a real pleasure to be part of this symposium. I'm just thrilled that you'd like to hear more about bone health in the Duchenne context. Now, the principles that I'm going to talk about today are applicable to any individual with subnormal mobility, as well as to any individual on chronic glucocorticoid therapy. So you can take that with you as you go forward. I'd like to start by acknowledging my funding sources, CIHR, and also, as Homira mentioned, Muscular Dystrophy Canada, who's funded a trial that you'll hear about, and Parent Project Muscular Dystrophy has also been a strong supporter, so I'm grateful for that. I do have a number of disclosures. I have been a consultant to and participated in clinical trials with industry who is working to get drugs to individuals with rare diseases with the funds to my institution. And all of the osteoporosis therapies that I'll talk about today are off-label in children, although they have been approved in adults. So the clinical endpoint we're talking about today is osteoporosis. You can see a normal graphic on the left and on the right an osteoporotic sample. Osteoporosis means that the bone is porous. There's holes in the bone because the bone has become thin. And you can even see that there's some little cracks in the bone here as well. Osteoporosis, of course, causes fractures with loss of stability of bone. And so this is a considerable issue and one that I'm so delighted to be able to comment on today. Now, I'm quite sure that the viewership is very familiar with Duchenne, but just to say that this is one of the telltale signs that we see clinically, that when the boy with Duchenne goes from the seated to the standing position, he walks his hands up his legs because of the muscle weakness. And you can also see the calf pseudohypertrophy here. Now, DMD, as you probably know, is caused by mutations in the dystrophin gene, usually deletion mutations. Dystrophin codes for the protein by the same name. This is a critical muscle protein because it acts like a molecular shock absorber, such as you can see on the left. And when the dystrophin protein isn't working well, then the muscle cell membrane becomes unstable and indeed fragile. And as part of the condition, there's an inflammatory response to that muscle membrane being unstable. And that's important for reasons that I'll talk about later. Again, I'm sure that you're aware that this is a condition that is intensely under study in children the world over, and probably unparalleled for its attention in clinical trials, actually, in the pediatric space. We think about treatment as being mutation non-specific or mutation specific. The FDA approved deflazacort for this condition, and the FDA has also approved exon skipping therapies, exon 51 and exon 53. There are no Canadian approved therapies to my knowledge, and there are a number of agents that are under investigation, as I said. So when we think about how bone development loses its strength in neuromuscular disorders, we first need to understand how it evolves when there is normal weight bearing. So this is what's called the mechanostat model of bone strength development. And what drives bone strength is bones getting longer and also muscle forces on bone. And then those mechanical challenges are sensed as bone tissue strain, and I'll show you what that looks like in a minute, by the osteocyte, the master bone cell. And the osteocyte sends signals to the osteoclasts, which are working in the trenches. I think of these as like the housekeepers. They move in and they resorb or take away the bone that's been damaged by tissue strain. And then the osteoblasts are like the renovators. They then move in and they lay down new bone at the site of tissue strain to keep that bone strong despite these increasing mechanical challenges throughout the growing years. Now, in Duchenne muscular dystrophy, or in any condition where there is subnormal mobility, we have muscle weakness, of course, and then there is a lack of bone tissue strain. And so there is a lack of signaling to those housekeepers and those renovators in the trenches to make bone as strong as possible. On top of that, steroids, which are standard of care for Duchenne, attack the osteocyte, which is the cell line that normally senses the tissue strain. They rev up the osteoclast, so there's an excessive amount of bone being broken down, and they put the osteoblasts, the cells that lay down new bone, they put those to sleep. So these are the ways in which bones can be fragile in this setting. So this is an example of bone deformation that would come with walking, running, or jumping. And then in response to that bone deformation, the osteocyte on the bottom right, this is the beautiful master cell that has these finger-like projections called dendritic processes. They sense throughout bone changes in fluid flow that are brought about as a result of the changes in deformation on bone. So here's this represented graphically. The circles are the osteocytes, and they, with their filaments, are sensing changes in fluid flow through this underground sort of canal system within bone tissue. And then once that happens, the osteocyte on the right secretes two key molecules. They modulate the secretion of sclerostin, which normally inhibits bone formation, and the osteocyte modulates its secretion of rank ligand, which revs bone resorption up. Now, this may look very busy and complicated. I'm going to come back to this later and contextualize this for you in the Duchenne and neuromuscular disorders setting. But to put it in perspective just a little bit more, so at rest in anybody sitting there now or who's had a critical health event, perhaps been bedridden, or anybody with subnormal mobility for any reason, sclerostin is downregulated by the osteocyte, and that prevents the activation of a cell line and signaling system called the Wnt signaling system, which normally would foster bone formation. With mechanical stimuli, with walking and running and jumping, sclerostin is downregulated, and that releases the inhibition on the Wnt signaling system, and new bone is laid down to make the bone bigger and to make the bone thicker. So with typical weight bearing, we see that as children get bigger in height, their bones get bigger in width. But in the muscle weakness setting, even when kids are getting taller, their bones are not getting wider appropriately. So this is called lack of periosteal apposition. And this is a major determinant of why children and adults with neuromuscular disorders fracture their long bones, like their arms and their legs. Now, this bears out in the MDX mouse, the mouse model of Duchenne muscular dystrophy. On the left, this is the femur, the biggest bone. You can see that it is just not as big as the other bone, and you can see that the cortex, this pillar around the bone, is also thinner than it should be. And so that's because of this lack of periosteal apposition, because sclerostin is being over secreted. So my clinical checkpoint here is that in individuals with subnormal mobility, they're at increased risk for long bone fractures because of lack of this increase in bone width, which we call lack of periosteal apposition. And this is even separate to bone density. Now, what about steroids? Steroids are used to treat Duchenne muscular dystrophy, as you know, and they have shown consistent benefits in clinical trials. They prolong ambulation on average by about 2 years. They decrease the frequency of scoliosis dramatically. I have not seen a boy with Duchenne go to scoliosis surgery on steroids for many, many years. They improve cardiorespiratory function, heart and lung function, which provides rationale for continuing steroids even after ambulation is lost, and they improve longevity. They exert their effect by dampening what's called the NF-kappa B system, also known as the rank ligand system. The issue with steroids, which we love for their benefits, of course, is that there's a narrow therapeutic window because of the potential for side effects. So, for example, there's double the risk of fractures if you start steroids before 5 years of age in Duchenne. And yet we'd love to start as early as possible, wouldn't we? Because this is a congenital myopathy. So that is the double-edged sword of steroids, and we're going to talk about that in more detail. There are 3 different steroid regimens that are commonly used around the world: daily prednisone, daily deflazacort, and intermittent prednisone. Daily deflazacort is most frequently used in Canada, in my experience. There is evidence to support that deflazacort helps with keeping the weight in check relative to prednisone. The intermittent prednisone is given in the spirit of trying to help muscle, but without quite as many side effects. And we're going to talk about that risk benefit in more detail as we go through the talk. Now, importantly, these 3 different steroids or ways of giving steroid are going head to head in a clinical trial. So today I couldn't sit before you and say what is the benefit and side effect profile of each of these relative to the other, because we just don't know. But this trial will answer the question for us. This study was carried out in Canada. You can see Dr. Jean Ma, Dr. Craig Campbell, Hugh McMillan participated in this trial in Canada, perhaps others. The study is over. You might have participated in this trial, and the data are being analyzed. So these results are highly anticipated. This is a study that came out of the North Star Duchenne Registry, which is a large United Kingdom-based registry of patients with Duchenne, looking at what happens to the probability of having a fracture in relationship to the duration of steroids. So you can see that by after about 8 years of being on steroids, there's a almost 60% chance of having a symptomatic fracture. And that does not take into account asymptomatic verbal fractures, which we'll talk about more in a minute. So at CHIO, for any child who's on steroids daily for 3 or more months, IV or oral, they come to see me in the clinic to start osteoporosis monitoring. And I think this is really important and a message that we're trying to get out. So all the boys with Duchenne at CHIO who are on steroids come to see me in the clinic. And the boys who aren't on steroid also undergo bone monitoring because of the fact that the weakness of the muscle can make those bones smaller than they should be. So that's a little bit about the background of this context. Let's talk now about the clinical manifestations of the bone fragility, whether boys with Duchenne can recover from osteoporosis all on their own without any medical help, how to diagnose and monitor osteoporosis, and how to treat. So we know that the muscle weakness largely drives the long bone and the other non-spine fractures, and that steroids can increase the fracture risk. We know that steroids largely drive the spine fractures, but that muscle weakness also contributes. So for example, we've just finished a study where about 3% of the boys not on steroids between 4 and 7 years of age had a little spine fracture. So we know the muscle weakness can also bring that about on its own, but the steroids largely drive the spine fractures, and you're going to see pictures of that in a minute. We know that these long bone fractures occur in about 30 to 60% of boys and adolescents with Duchenne, and that they're more often on steroids. The most frequent sites are the tib fib, so the bones from the knee to the ankle, the femur, the biggest bone in the body, followed by the humerus, the upper arm portion, and the forearm. And what I don't like about long bone fractures is that they can cause permanent premature loss of ambulation. I don't need to tell this audience that if you or your boy are expecting to walk on steroids till at least 12 years of age, and then you have a fracture of the femur at 8 and you lose ambulation, that's absolutely devastating. So I care about this very, very much. The other thing that I think is important for this audience to understand is something that's very, very rare, very unlikely to happen, but I think you need to know about it because it has been described in Duchenne by Laura McAdam and Doug Bigger at Blurview. So this is something called the fat embolism syndrome. So here's what we know. In anyone with subnormal mobility and in anyone on steroids, even one or the other, there can be an accumulation of fat cells called adipocytes in the bone marrow, particularly of the femur. And then at the time of a fracture, or even just a bone injury without a fracture, just a fall and a bone bruise, those fat cells can coalesce into fat globules in the bloodstream and get into and shower the lungs and also cause neurological deterioration. This happens rapidly after a fall or a fracture within a few hours. It's very serious. You must seek urgent medical attention if this happens. Again, unlikely, but we did want to raise awareness. These are what the bones look like in Duchenne, and I would suggest to you that this is the way they look in anyone with a neuromuscular disorder, whether it's cerebral palsy or spinal muscular atrophy, etc. Non-weight bearing gives this kind of shape to bone. So first of all, you can see on the left that the bone is thin, it's gracile, and that's because of that lack of periosteal apposition. You can see that the bone looks darker, that means it's thinner, because on an x-ray, a thicker bone is more white. You can see that up the femoral shaft here that the cortex is thinner than on the right. And you can also see there's a little crack here. And this is a classic fracture that comes about just tripping over the flowers in the carpet and then falling on the knees and having this little crack. Spine fractures are also an important part of this discussion. They're frequent in Duchenne. This is an example of the patient who got me thinking about this many years ago. 13-year-old boy with Duchenne who was admitted to the emergency room with back pain after 5 years of deflazacort, and we had no precedent for any sort of spine monitoring all these many years ago, and the bones in his back are flattened, and you'll see another example of that in a minute. And then a bone biopsy showed advanced osteoporosis. And we know vertebral fractures can cause pain, kyphosis, but also premature loss of ambulation in a boy who has tenuous ambulation. So if a boy is within 6 to 12 months of being non-ambulatory and has advanced painful collapse, that can hasten that non-ambulatory phase. So we really care about vertebral fractures as well. We know that they're frequently symptomatic, but also frequently asymptomatic. And so we have to go looking for these. And that's a big part of what I'm going to be talking about today. This is an example. This is an 8-year-old boy with Duchenne. He has a beautiful spine at baseline. A year later, I've done another x-ray, and he has the very earliest sign of a fracture at T9, sort of a little bit below the shoulder blades. And you may look at that and go, well, that doesn't look too bad. But in fact, your vertebral bodies should maintain their height and be able to support your weight above them. So for us, this is a definite sign of osteoporosis. Years ago, we didn't know what to do with this. We left it alone, and then that T9 will progress if you do that, and then we have more fractures adjacent. This is called the vertebral fracture cascade, whereby in any patient with persistent risk factors for osteoporosis, fractures at time point A predict new fractures later. So why do we care so much about vertebral fractures? Well, in children, steroid-treated children of any ilk, we've shown that they cause back pain, hunching forward called kyphosis, and loss of vertical height, and then this permanent premature loss of ambulation in boys with tenuous ambulation to begin with. In adults, they're also linked to back pain, kyphosis, and loss of height. But in adults where they have larger numbers of patients to study, vertebral fractures have also been linked to reduced lung function. And I think in this context, that's vitally important. So you can imagine that if your vertebral body is supposed to be this tall and it shrinks because of a fracture, that's going to limit the extent to which you can take a deep breath and really fill your lungs up with air. These are some examples. This is what we would call a mild vertebral fracture. This is a moderate fracture, and this is a severe fracture. So our goal, our job as clinicians is to pick them up in their very earliest stages. Now, I've been very interested in when first vertebral fractures occur, because if I'm going to prevent those or minimize their occurrence, I need to know when to start looking for them. So this was a study that we did, a retrospective study looking at all the boys that had been referred to my clinic over 15 years. In green, these are the boys that had spine x-rays every 1 to 2 years after starting steroids. In red, these are the boys who presented with back pain with no monitoring in the era when we didn't know we should be monitoring. And the results are very intuitive. You can see that if you monitor for spine fractures, they first appear around 9 years of age in this cohort compared to 12 years of age if they just come to you with back pain. If you monitor the boys, they'll come after about 2 years of steroid therapy, the very earliest signs, as opposed to 5 years if you don't monitor. If you monitor the boys, you'll pick the vertebral fractures up when there's only about 1, maybe 2 maximum, as opposed to if you let them present with back pain, they'll come and they'll have about 5 fractures on average per patient. And then if you pick these up early, the bone density is that much more preserved, with 0 being average, as opposed to if you wait until they present to medical attention with back pain. And in that case, they're below average, less than -2 for a Z score. The other important thing we learned from this paper is that you can have a fracture at a young age, and that can be a first osteoporotic event. So this is a boy, he had a fracture of the tibia at 6. I don't have an x-ray because I didn't see him. And he returned 7 years later with a completely collapsed spine. His very first episode of osteoporosis was at 6. And now, all these years later, now that we know more, we would recommend treating at that first long bone fracture. So my clinical checkpoint is that a single long bone low trauma fracture can signal an osteoporotic event in individuals with neuromuscular disorders. And low trauma is defined as falling from a standing height or less at no more than a walking speed. Now, we're already a good portion into the conversation, and I haven't even mentioned bone density. And why is that? Because the most important thing for me is how the patient is doing. Number 2 is the x-rays, and then the bone density is a guide, but it's not the full story. But this is how we use bone density. We like to have multiple measurements so we can see its direction. In this boy between 8 and 11 years of age, you can see that the hip bone density declined. You can see that the total body BMD was stagnant, but not quite as significantly declining as the hip. And you can see that the spine held on a little bit longer and then declined. And so my message here is we need multiple BMDs to really understand the trajectory of a child. And we need to look at different skeletal sites to fully understand the phenotype as well. Now, a really important question that we ask ourselves when we see children with chronic illnesses and osteoporosis is whether they can recover all on their own without us having to intervene with a medication. And so on the right, you can see recovery. The pediatric condition that best exemplifies vertebral body reshaping, which only occurs if a child is growing, is leukemia, because the children are young when they're diagnosed. They're on high-dose steroids for 2 to 3 years, and then most children go on to recover from their leukemia. So you can see this very nice vertebral body reshaping after an initial vertebral fracture in this child with leukemia. Now, in Duchenne, there is no reshaping of vertebral bodies based on what we know to date. We have not seen it, it's not been published. And why is that? Because this is growth mediated. The boys on steroids do not grow optimally, and you can see that down here on the growth chart. The steroids are long-term, the myopathy is progressive, and that vertebral fracture cascade is in motion. So people have asked then, can we tinker with the steroids to try to protect bones? And the answer is yes, but it looks like you may do so at a cost to muscle strength. This is a publication out of the UK looking at boys on daily prednisone in green versus intermittent prednisone in blue. And after 2 years on the far right, the boys with daily prednisone, 40% had vertebral fractures compared to 8% after 2 years of steroids when they were given in an intermittent fashion, days on, days off. But when you read the paper, the boys on the intermittent therapy didn't do quite so well from a muscle perspective. And I maintain that it's best to really treat the underlying disease as your top priority, and we can take care of the bones. And we think of that as a secondary issue, but focusing on the muscle health. So a very tricky situation here in terms of the relationship between steroids and bone health, but I'm talking to you about what we can do to protect the bones so that the boys can stay on their steroids. So what I want to tell you is that steroids tickle the bones in everyone. It doesn't matter who it is. If you're on enough steroids for long enough, it will tickle your bones. And we combat the effects of steroids with early bone protection. And so this is what I'm going to finish by talking to you about today. Now, there is a compound that's under trial right now called vamorolone. VBP15 is its bench name, and it is being interrogated in clinical trials to see whether it can have benefit to muscle with fewer side effects. It is a steroid, but it is a dissociative steroid. It retains its anti-inflammatory properties, but it has fewer glucocorticoid response element activities, which means that we hope that there will be less side effects. The mouse model of vamorolone was favorable. So the mouse was taller and it had reasonable muscle strength and the bones looked better. But as you well know, just what we observe in mice does not necessarily translate to humans. So we are now working on the clinical trial of vamorolone in boys 4 to 7 years of age, comparing this dissociative steroid to daily prednisone and daily placebo. So let's finish up now about this notion of bone protection. And what I want to tell you here is this is an aggressive osteoporosis, so it has to be met with an aggressive approach. We certainly talk about conservative ways to optimize bone health, but this will not prevent fractures alone, so we have to go beyond that. We talk to the families about addressing nutritional deficiencies. We do recommend treating delayed puberty, provided that the boy is open to that. Usually by 14 years of age, we get that conversation going. Some boys are more or less ready to have that conversation, and we do take our cue from the boys and when they're maturationally ready to go on some testosterone, but it is part of the dialogue. We talk about the importance of a healthy weight. If you are overweight and you fall, you've got more weight on those already fragile bones. I talk a lot about fall prevention, especially in Canada, both to caregivers and to boys with Duchenne, both in the ambulatory and the non-ambulatory phase. Important to think about fall prevention. And I go as far as recommending those yak tracks, which go on the bottom of your shoe to help you grip on the ice, because I've seen so many slips and fall on the ice in all kinds of contexts. Growth hormone is not routine. We do not think that there is a sufficient safety or benefit evidence, and we discuss that extensively in this paper here, and I'm happy to take questions on that. So we protect the bones with bisphosphonates, which are part of the anti-resorptive class of medications. And there's other medications I've listed here that we'll touch upon briefly, but they are either in trials or used theoretically. So I'm really going to focus on the standard of care and just say a few words about these other agents. So let's talk about bisphosphonates. Now, whoever thought to put an S and a PH twice in one word? So, you may want to practice this, bisphosphonates. These are the most commonly used medications for osteoporosis the world over. And what do they do? So in the healthy situation, the osteoclast resorbs bone at the sites of damage. In osteoporosis, that osteoclast is overactive and it resorbs too much bone. Bisphosphonates are taken up when the drug hones to bone, because that's what it does. The rest of the body is not interested in bisphosphonates per se. And the osteoclast takes up the bisphosphonate into its cellular machinery and it goes to sleep. It is stunned. So it's still there. We see it under the microscope, but it's not as functional. This is my lay version of the same concept. These osteoclasts, some of them are sleepy when you're on bisphosphonate therapy. IV bisphosphonates are the most frequently used agents in children. They're long acting, which I think is a good thing in Duchenne because it means we don't have to give it very often in a condition where we want to treat the bones long term. They're very effective for pain relief, particularly at the spine, and they perform better than oral bisphosphonates. So there's been a number of studies that have been done in different diseases showing that the oral availability, we call it bioavailability of bisphosphonates, is very low, less than 1%. So not much of it gets to bone. Whereas with IV bisphosphonates, 80% of it gets right to bone. It is an intravenous poke. It does make the bone a little bit sleepy. And there are some first infusion side effects, which we'll talk about in a minute. So there are two kinds of bisphosphonates used in Canada, intravenous pimidronate and intravenous zoledronic acid. Pimidronate is given over 4 hours. It's a little gentler with its first infusion side effects, and it's given every 4 months. Zoledronic acid is just 1 hour. It's given every 6 months, but there's a little bit more in the way of severe first infusion side effects, and I'm going to talk about that more in a minute. Now, I only use pimidronate in children who are critically unwell, such as children with cancer who are admitted to CHIO or children critically unwell otherwise. Boys with Duchenne are constitutionally quite robust, and so we use zoledronic acid. And we're trying to prevent fractures and prevent back pain and prevent those declines in BMD. Now, the first dose side effects are not insignificant. And so these drugs have to be administered by somebody with expertise in their delivery and by somebody who's prepared to be on a pager in the few days after the infusion to support families. When the osteoclast goes to sleep, it secretes some inflammatory cytokines. Just like when you have a cold, your body fights the cold with an inflammatory response. So that's how you kind of feel. You feel like you have a cold and you sort of ache and you have some fever, some nausea. We give a medication so that we don't get any vomiting. We use Advil to treat the fever and the bone and muscle pain that happens as the drug gets into the skeleton. And we also give calcium and vitamin D supplementation to prevent low calcium. Now, often boys are on steroids, and when you have fever, sometimes you need more steroids. So we counsel the families around that. And as I said, we have a physician on a pager to help the families through if they have questions. I've never seen permanent side effects. They start 24 hours after the infusion. They last typically 24 to 72 hours. Rarely do they last more, and they usually are only with the first infusion. Sometimes families will come back and say, yes, my son didn't feel quite right with the second infusion, but it's usually not as it was with the first infusion. This is a representative example of what happens on zoledronic acid in the Duchenne setting. This is a boy on steroids. He's 8 on the left. Where the arrow is pointing, there's just a little fracture there. It's just a very early sign. You can see his spine bone density, these squares, was flat. And we started him on zoledronic acid, and I titrated his doses to achieve a normal rate of bone and mineral accrual. And so by 17 years of age, he has no back pain. He's off to college. He's doing extremely well. And you can see nice densification of his bones on the spine here at 17. Now, I've pointed out with the arrows that despite a normal bone density, despite that being visual to you with that white outline on the spine bones, he still has some vertebral deformity. And we think that this is not due to osteoporosis, but because of the hyperlordosis, that sway back, which is excessive in Duchenne and interferes with the way the spine is biomechanically lined up. So if there is progression in deformity, that in my experience is what we do see from time to time. Now, this is a study that is under review for publication, so I can't show you pictures of the data till it's published, but this was looking at IV zoledronic acid versus IV placebo in patients, children with steroid-induced osteoporosis. They all had vertebral fractures at study entry, and 38% of the children had Duchenne. And what we saw was that the bone density of the spine went up more, and significantly so, on zoledronic acid compared to on placebo, that both groups had quite a few side effects. So even on placebo, there were quite a few side effects, and that the only new vertebral fractures were in the placebo group. So that's a very important study because it is placebo controlled. So with all that background in mind, this is the current standard of care for monitoring and managing osteoporosis in steroid and non-steroid treated Duchenne. Know that in 2010, the guidelines were that you just do a spine x-ray if there's back pain or if there's that forward bending, and you only treat if you have vertebral fractures, and you do so with IV bisphosphonates. Now, those were very reasonable recommendations in 2010 because that was based on what we knew at the time. In 2018, we're a lot smarter. We know that those vertebral fractures are frequent in Duchenne. We know that they're asymptomatic. We know we need to go looking for them, and we know that they predict future fractures. We also know that a single long bone fracture can represent an osteoporotic event. So now we recommend looking for vertebral fractures, treating them at early signs, and also treating a first long bone fracture in a patient at risk. And you may be saying, well, why not start even before there's fractures? That's a great question. I think we're headed there, but we don't have the evidence, the studies, the trials to justify that at the moment on an international basis. So here's how it looks laid out. We have a monitoring phase. We treat early signs of fracture. We keep the bisphosphonate therapy going for as long as the boy is on steroids, and maybe even longer if there's still unmet bone needs. And we induce puberty when the boy is ready to do so if there's delayed puberty, usually by 14 years of age or sometimes later. The most important part of this montage is the monitoring phase. So we recommend annual bone densities in these patients with Duchenne. If they're on steroids, we recommend a spine x-ray every 1 to 2 years. If not on steroids, the spine x-ray is every 2 to 3 years. And we do the spine x-ray even more often if the bone density drops by more than half a standard deviation. So that's why we do the annual BMD. And then we treat early signs of osteoporosis. We do not wait till it's advanced. And we continue the bone protection for as long as the steroid therapy is on board, and maybe even longer if necessary. So my clinical checkpoint is that IV bisphosphonates are started at the first sign of low trauma fractures in boys with Duchenne, and first infusion side effects require anticipatory management. So in the last couple of minutes, I'm going to just finish up by talking about where do we go from here. So I've just finished mapping out the standard of care. And what does standard of care means? It means this is what we would hope and expect that boys with Duchenne in Canada are receiving in terms of their care coast to coast. And we're also trying to get the message out internationally. In terms of where we go from here, now I'm just talking scientifically from a free academic perspective, theoretically about what's on my mind as we go into the future. So I want to first talk about rank ligand inhibition, and this is the study that was funded by Muscular Dystrophy Canada. First of all, this was the mouse work that was done by my colleague in Quebec City, and he noted, Jerome Fredette, that rank ligand is secreted by bone. It causes bone breakdown, but it's also part of the muscle inflammatory pathway of Duchenne. And he thought, well, if we shut down rank ligand, can we make muscle better? And so he did a study giving anti-rank ligand antibody to the Duchenne mouse. and found that there was improved muscle strength, less muscle damage, and lower CK levels. Now, he hasn't looked at the effect of anti-rank ligand antibody on bone. However, we know that if you shut down anti-rank ligand antibody, you give it rather, that you improve bone strength. So that is something that requires further investigation. Now, what Muscular Dystrophy Canada has specifically funded is a pilot study of denosumab versus zoledronic acid in boys with steroid-treated Duchenne. And so this is a 2-year study, and MD Canada funded the second year because the first year went so well. I needed more funding to continue it. All the patients wanted to stay on the study. The results were favorable, and we gave denosumab 1 milligram per kilogram every 6 months subcutaneously, a little injection in the skin, compared to the standard of care, zoledronic acid, also every 6 months, but intravenously. And we had 10 patients in this pilot study, 5 in each group. 8 of them had steroid-treated Duchenne. And we did a sophisticated number of investigations looking at bone density and fractures, and we checked their calcium profile carefully. And I can tell you the results have been favorable, and all of the boys who were on denosumab have stayed on denosumab, and we are now writing up these results. The study is over. It was audited by Health Canada. We passed the audit, and I'm really grateful for the families that participated in this trial and for my team members who were on this journey with me. Clinical trials are not easy, and we are delighted to have been able to do that. And so I'm just going to finish up with a last word to say that these anti-resorptive drugs, zoledronic acid and denosumab, they work best at the spine and the hip because that's where we can modify the bone density the most. These drugs do not make bones bigger, and that's where we need to go in the future. So the door is open, and there is a drug that's been approved for adult osteoporosis that makes bone bigger called anti-sclerostin antibody. It releases the inhibition on bone formation. This is an anti-sclerostin antibody treated mouse on the left. Sorry, this is a non-anti-sclerostin antibody treated mouse on the left. On the right, the rat has been exposed to anti-sclerostin antibody, and you can see that with that drug that the bone is bigger and thicker. So this is a medication that interested me a lot as I think about going forward in this space. So my take-home messages for you today are that osteoporosis is a complication of neuromuscular disorders, both with and without steroids, and you've heard why. Low trauma fractures signal osteoporosis in neuromuscular disorders and merit treatment, particularly at the spine and the long bones. And the spine needs to be monitored periodically for asymptomatic signs of collapse so that bone protection can be started as early as possible. And with that, I'd like to thank my colleagues who are in Ottawa and Montreal working closely with me, particularly my team, this long list of people who are dedicated every day to the study of children with osteoporosis in different contexts, my Canadian collaborators, my international collaborators, and a very special thank you to Muscular Dystrophy Canada for your support as we inch forward in this space. So thank you, and I look forward to your questions.
Thank you very much, Dr. Ward. That was an excellent and very clear presentation. I mentioned to you prior to our session that individuals are really keen to hear about those grants that we fund here at MDC, seeing those donor dollars in action, and it's wonderful to see the results of this study and of your work and your program of research. We have received a few questions, so I'll go ahead and read them out loud. One of the questions we received is, after a fall, what are the signs to look out for? And that was in regards to that fat embolism risk that was mentioned. Would a child have chest pain, trouble breathing?
Yeah, thank you for that question. It's so important. It's rare, but I do feel you need to know about it. So after a fall, shortly thereafter, it can be within minutes to within a few hours. The first thing is neurological deterioration. So the boy will be just confused and disoriented. And, you may just think, well, he's hurt. He's not sort of making sense, but no, it's actually neurological effect of that fat embolus getting into the brain. And then the respiratory distress, difficulty breathing, right? So hard to get a deep breath, breathing quickly. Those are the two main signs. And the boy that I met a young man recently as part of a PPMD endeavor, and he said he was in his wheelchair. He fell out of his chair. He didn't have a seatbelt on. He fell off a ramp. And he remembers his dad rushing to his side, and then that's it. He didn't remember anything till he woke up out of the ICU. So it's pretty quick. Know that if you're on steroids, anytime you have a critical health event, you need to remind the doctor, my child, my loved one is on steroids, and they need to give extra steroid, because that's what the body would normally do, is create more steroids to help fight that critical medical event. So thank you for that question. That's an excellent one.
Yeah, very important information. A question that we also received is, how much vitamin D is too much for someone with a neuromuscular condition? And is that any different for a child versus an adult?
Yeah, that's a great question. The thing I love about vitamin D supplementation is that you can actually titrate it to a level, so you don't have to guess, because the dosage is actually variable. Now, most people, to maintain normal levels above 50 nanomole per liter in Canada, most will just need 1,000 to 3,000 IU per day. But what is it? Is it 1,000 or is it 3,000? And that's where we use the vitamin D level. It's best measured at the end of the winter when it's lowest, and you want a level above 50 and ideally closer to 75. And so 1,000 units of vitamin D raises your level by about 25. So if your level is 40 and you want to get it above 50, you can take 1,000 and you'll be in the 65 range and you'll be good to go. So those are the parameters that we use to guide dosing for vitamin D. Thank you.
Thank you. An individual mentioned they've been taking Prolia since 2013 and it's working really well. Will they have to change medication in the future? And is there any studies related to that?
Yes, thank you. So Prolia, for those of you who aren't aware, is denosumab. So that's the medication that I've compared in the Muscular Dystrophy Canada trial to zoledronic acid. Now, Prolia is a very effective anti-resorptive, but here's the thing, and the patients that I enrolled in the study all were aware of this when they entered the study. It is an antibody to rank ligand, and if you stop and don't do anything further, the antibody wears off and the bone density can go down and you can, go backwards. So when you're ready to discontinue the denosumab, the Prolia, you have to seal in the effect with a bisphosphonate, a long-acting bisphosphonate like zoledronic acid. So I would say that it's reasonable to be on denosumab until you're very happy with the clinical status. And then around the time that your physician would normally be thinking about perhaps transitioning off the denosumab, you would need to seal in the effect with a few doses of long-acting bisphosphonate like zoledronic acid. So thank you for that question. That's a really important one. You guys are hitting on all the most important questions I didn't get a chance to talk to in the talk.
These are great questions. I'll ask one more question and pass it over to my colleague Marie-Helene. The other question is, there seems to be differences in terms of endocrine clinics rules around when they provide treatment. So this individual's clinic does not provide treatment until there is more than 2 fractures. Can you speak to that? Would you agree?
Yeah, that's a great question. And I don't agree, but I understand it. And I want to tell you the history. The dial on the change in standard of care takes time, and it takes time to get the message out. And I understand your clinician in that a few years ago, the recommendation was not to say that a child had osteoporosis until they had 2 or more long bone fractures by 10, or 2 or 3 or more long bone fractures by 19 years of age. Those were the recommendations for long bone fractures. Now, you just needed 1 spine fracture to be said to have osteoporosis, but I think you're talking about long bone fractures here. The problem was that those guidelines were actually meant for otherwise healthy children who are running around on the playground and trip and fall and fracture, and we didn't want to overdiagnose those children. They were never meant to apply to children with chronic illness. Somehow the message got lost, and I actually just wrote a paper with some international colleagues a few months ago, and I'd be happy to send it to you if you email me. that untangles this misunderstanding. If you have a chronic illness and you have risk factors for osteoporosis, and particularly if those risk factors are persistent, like weakness, like long-term steroids, a single long bone fracture constitutes osteoporosis. Now, what's a long bone fracture? Humerus, upper arm, radius, ulna, forearm, femur, tibia, fibula. Little fingers and toes, we don't think you have to rush to treatment for those based on our current understanding. Another fantastic question. I think you guys must have just gone away and read the literature before you came to this talk, because your questions are just so on point.
Thank you so much, Dr. Ward. I will pass it over to Marie-Hélène. She'll read the questions and you'll hear the translation, but you're welcome to respond in French if you'd like.
Alors, Dr. Ward, j'ai deux questions. La première, qu'en est-il de la prise de poids? Mon garçon a pris le déflazacort et il a pris beaucoup de poids. Il a dû cesser de le prendre.
Oui, alors merci de votre question. C'est vraiment difficile avec les stéroïdes. On sait qu'ils poussent le poids chez tout le monde. C'est pas juste à cause du fait qu'il a la maladie du Duchenne. Il pousse l'appétit et c'est pour cette raison que les patients engraissent. Alors, c'est difficile et je pense que c'est une question d'être courant de ça et d'essayer de faire les choses à la maison pour améliorer le poids, de travailler avec une diététicienne. Et aussi, je pense que c'est pour cette raison qu'on est en train d'investiguer les autres médicaments qui vont avoir moins d'effets au niveau de l'obésité. Alors, c'est une très difficile situation, je comprends.
Merci. Ma deuxième question, c'est mon garçon présente une scoliose et il a très mal au dos. Est-ce que ce serait possible que ses vertèbres soient fracturées et que nous ne le savons pas?
Oui, absolument. Comme j'ai dit dans ma présentation, les fractures vertébrales peuvent absolument être sans symptômes. Alors, la maladie dans le dos pourrait être à cause du fait qu'il a les compressions vertébrales et que ça peut causer la douleur, ou c'est possible que c'est juste la déformation de sa colonne, mais ils doivent avoir une rayon X latéral en profil et comme ça, vous pouvez bien visualiser les vertèbres. Alors, ça, c'est quelque chose que je suggère fortement, absolument.
Merci, c'est tout pour moi.
Merci de votre question.
Thank you again, Dr. Ward. Thank you for taking the time to present this information to us in such a clear and easy to understand way, but also taking the time to answer the questions that we have received. I would also like to thank PTC, Biogen, Roche, Alexion, Novartis for supporting education initiatives like this one. I welcome you all to attend the remaining 2 sessions for this afternoon. The next one is on cough and respiratory health and neuromuscular conditions. And the one at 3 p.m. Eastern is on balance and falls and neuromuscular conditions. Thank you again, Dr. Ward, and thank you all for attending today's session.
Plaisir, merci.